Metabolically healthy, super healthy. Can you still get heart disease if your LDL cholesterol is high? So there's been this movement online the last few years where a bunch of people think that if they are quote unquote metabolically healthy, that their LDL does not matter. And they think that they've discovered some new science that nobody else has access to or has never been studied before. Nothing can be further than the truth. This has been studied forever. I mean, we have multiple studies on this, and I'm going to start discussing them as we kind of go along. I'm going to break this video down into two main sections. The first section is just kind of me off the top of my head discussing this topic. Then I'll dive deep into the studies, and there are tons of them. You might get kind of bored when we dive into the study section. For those of you who don't know me, my name is Dr. Allo. I'm a board certified cardiologist. I'm an internist. I'm a certified personal trainer. I'm a hobby chef. I wrote the book on cholesterol with Dr. Thomas Dayspring, who is the world's greatest lipidologist. So this has been studied before. Unfortunately, there's a group of people who, whether they like it or not, they are misinforming the public and telling people that high LDL cholesterol, if you're quote unquote metabolically healthy, does not matter. And this is not true. If you follow me around the hospital for a day or two, you will notice that in the hospital, we have plenty of people that are in their 30s and 40s that are super young and metabolically healthy that have heart disease. So this is not some new discovery that's never been looked at before. I mean, they try to paint the picture. This has never been looked at before. Nobody's ever studied this. And, how come, no one knows about this? First of all, this is a bunch of nonsense. If you really discovered something amazing, come on over. Come to a cardiology conference, present your data, and let's see what you come up with. Obviously, this is just a bunch of nonsense, but let's kind of go over. So there are several studies that have been done, and we'll get through each of them, with great detail so that you kind of know the studies. Now, I'm not going to go through every single one of them. You can buy Cholesterol Truths, the book, and read this chapter in there, plus like tons of other stuff. It's a 516-page textbook on cholesterol, lipids, lipoproteins, and it's full color. It is an 8.5 by 11 huge book. If you don't want to do that and you want it for free, this chapter is free on my blog. If you go to drallo.net/blog/LMHR, that stands for Lean Mass Hyperresponder. If you go to that, literally the entire book, that chapter of the book is copied word for word into the blog. But what it has in addition to what the book could not have is the actual images and pictures from the studies themselves. The publications would not let us publish their images because it's obviously copyrighted, and you can't sell someone else's copyright without paying thousands and thousands of dollars. To publish one image was going to be $3,800. The book has over 800 studies in it. If you do the math, that was probably going to cost, I don't know, $2 to $3 million to produce this book at about $4,000 a pop for 800 studies. So that was not going to be feasible, and it was just not going to happen. So we took out all of the images. The book was almost 800 pages at first with all of the images. So we were able to take those out and get it down to about 520-ish pages. And none of those images are there, but they are all on the blog. The blog is free, so you can publish whatever you want on the blog. So I highly recommend that you check out the blog. So we're going to hit the study section. And what I'm going to do is basically I'm just going to read to you parts of the chapter of the book. And as I'm reading it, I'm going to put up the graphics and the images and the slides that go with it so that you know exactly what we're talking about here. The first part is from Dr. Deidre Tobias. She is a Harvard epidemiological scientist and a nutrition scientist, and she knows a lot about this topic. And she wanted a few years ago to prove the point that this has been studied before. This is not something new. This is not a new discovery. This population of people has been studied before. The group online did this 5-year recruitment phase where they tried to recruit all these lean mass hyperresponders, and they defined it as somebody whose triglycerides are really low, HDL is high, and their LDL is astronomical. And it's all diet induced. And the leaner you are, the more your cholesterol is higher, and all this kind of stuff. Although they've recanted the lean part, that you don't have to be lean. I don't know why. Maybe they couldn't recruit enough people. But either way, they found about 70 people, and their whole hypothesis and study is based on these 70 people, which I don't know why we are only studying 70 people. Now, a lot of people who have studied this before a lot of people who have talked about this before have stated that they probably have some kind of genetic mutations in their ABCG5 and G8, and that is why they have this super high cholesterol when they switch to a keto or saturated fat type of diet. Most people who eat saturated fat, their LDL cholesterol will go up a little bit, but these people hyper respond or what have you. And so the question is, do they have some type of genetic mutations that we haven't discovered yet? And the funny thing is, they did this 5-year recruitment phase and only found 70 people on the entire planet that met their criteria. And then they have been criticized heavily because a lot of the data and statistics that have been used, and I'll go through what some of the other scientists have said about that, seems to have been misprinted or misinterpreted, miscalculated, whatever the word is. I'll just read you a direct quote from some of the journals that they tried to publish in. So Deidre Tobias is an assistant professor in the Department of Nutrition at Harvard University. She is an obesity and nutrition epidemiologist. She set out to answer this exact question. As a specialist in epidemiology, she is an expert in this field and in data analysis. Yes, it's been answered before, but she wanted absolute certainty and to provide a detailed review on this topic. So she conducted this analysis on the Women's Health Study database. This is a large database of women. They excluded women with prior CVD, just like this study. They excluded people with prior atherosclerosis, which is kind of weird because you're not going to show any progression. I mean, you have to wait decades to show progression. They did the study, for a handful of years. So back to this text. They excluded women with prior CVD, cancer, or diabetes. She wanted only metabolically healthy participants. She ended up with 19,057 women in her cohort for analysis. These were women with normal blood sugars, low triglycerides, high HDL cholesterol, and an LDL cholesterol level available for analysis. The metabolically healthy cohort women she analyzed were, from her paper, they were leaner, more educated, higher income, non-smokers, active, and drinkers, slightly drinkers. As the LDL cholesterol went higher and higher, the women were older, higher BMI, postmenopausal, and had modestly lower education and income. She adjusted for these confounders. She evaluated baseline lipids, follow-up lipids, and long-term follow-up 20 plus years for death. She obviously removed statin users. They took out all statin users. The overall population was stratified on their HDL and triglycerides. They had to have HDL equal to or greater than 50, triglycerides less than 100. She then divided the participants based on highest and lowest LDL quintiles. Quintiles meaning when you divide by 20. The top 20%, the next 20%, the next 20%, the next 20%, and then the lowest 20%. And they looked at these 5 cohorts. These are called quintiles in statistics and epidemiology. She adjusted for smoking, obesity, BMI, and other confounders. Now, the chart I'm going to put up here is the very first chart from her analysis. And you'll notice the pink line is the line of the highest LDL cholesterol when you corrected for everything else. This was the result. The pink line at the bottom is a survival curve for those with the highest LDL cholesterol. The highest quintile had the lowest survival rates. You started to see separation at around the 5-year mark. So these people are doing this study for like 4 years or 2 years, and they're like, oh, let's see if there's a difference. You're not going to find a difference, especially if nobody has atherosclerosis to begin with. At the 5-year mark is when you start to see the separation between the lines. The higher the LDL cholesterol, the lower the survival. What if she went even stricter? What about if we only wanted the very best metabolically healthy individuals? She removed people with hypertension, BMI over 25, A1C over 6.5. Here's a survival chart from that group, except that the difference between the highest and lowest quintiles was now even more profound. So she ran it again with stricter criteria to pick people that are even more metabolically healthy, and she found that the lines separated even more. The people with the highest LDL cholesterols actually died the most, had the lowest rates of survival. Her conclusions were very clear. Women with higher LDL cholesterol, regardless of many other metabolic factors, were more likely to die during follow-up. This isn't news. We have known for years that elevated cholesterol, regardless of anything else, increases CV and all-cause mortality. The higher your LDL cholesterol, the more likely you are to die and the sooner. But this was one way to make it absolutely clear for the LDL and cholesterol disputers. And the disputers are these people that think that LDL cholesterol doesn't matter. I don't know why people still think this, but I guess it's a thing online. Especially if you're like trying to bend the science to fit your diet. If you want to eat a bunch of saturated fat and red meat, go for it. But why do you have to make up science and bend the science to like say that it's okay? You know, there's no reason to do that. I eat red meat. I don't make up stuff about it. You know, I eat chicken, I eat salmon. Sometimes I even eat pizza. Like whoop-de-doo. You don't have to make up science and bend the rules or find this one exclusion or this one really weird study on 10 people in Japan or whatever. You don't have to make up stuff. You want to eat your meat and whatever, eat it. No one cares, but don't make up science and try to bend the science because you just look foolish and you look like you are not only uneducated, but deceitful. You're trying to deceive people with what you're actually doing. You can access her paper, and you know there's the you can find it in the book, and you can find it on my blog. Another great article on this topic was done at The Ohio State University. By the way, congratulations, Ohio State fans like myself, winning the national championship game. This new format with 12 teams, we're probably just going to win almost every single year. The study was called The Effects of Carbohydrate versus Fat Restriction on Lipid Profiles in Highly Trained Recreational Distance Runners, a randomized crossover trial. Now, these were super lean distance running athletes. This was a trial on very lean, super athletic individuals who started out on a high carb, low-fat diet and switched over to a low-carb, high-fat diet. They measured the lipid profiles of these athletes. This was not a huge trial by any means. They included 7 athletes. They concluded that healthy athletes with no prior cholesterol problems on a low-carb, high-fat diet demonstrated elevated LDL cholesterol and high-density HDL cholesterol. And I'm going to put the charts and graphics up here. If you'll notice, charts A, B, and C that were plotted were total cholesterol, LDL, and HDL. All of them went up. We know what happens when LDL is elevated for decades, even in otherwise healthy runners. They had a 38% increase in LDL cholesterol. Even their triglycerides went up. So these lean people who decided to do this, high-fat diet and no carbs or low carbs ended up with high LDL and high triglycerides. And all of these studies are linked up on the blog. I said if you go to drallo.net/blog/LMHR or just search LMHR on the blog, you will find this article with live links. You can go and read these articles yourself, look at the graphics, evaluate it. A lot of people say, well, what about this study and that study? Go read the studies. I'm not making this stuff up. I'm not misinterpreting the studies. You are welcome to click on them if you're a genius and you think you can interpret studies on cholesterol and athletes and whatever. Please, by all means, go do. Next section. In perhaps the most compelling study ever done on young people with no prior history of CVD, the PESA trial, Prevention of Early Subclinical Atherosclerosis, looked to answer this exact question. What if we examined young people with no known atherosclerosis and tried to assess their risk? They looked at 4,185 participants with a mean age of 45. Mean means half the people were under 45 and half of them were over 45. Only 15% of them were obese, 37% were women, and they used 16 types of very fancy imaging to assess atherosclerosis in 5 different vascular beds. These imaging techniques are not available to us as clinicians. They are basically only available in research centers. They are quite expensive. Only 18% had a calcium score that was positive, meaning like 0 to 99. So out of this large cohort of 4,100, almost 4,200 people, very healthy overall, no atherosclerosis, no calcium, no advanced disease basically, and pretty healthy. They found that 63% of all participants had atherosclerosis in at least one arterial bed. Of those with atherosclerosis in one bed, approximately 63% had atherosclerosis in more than one arterial bed. So 60% had atherosclerosis and 63% had it in more than one arterial bed if they had it in one bed. They also found that of those with a calcium score of 0, 60% had subclinical atherosclerosis in at least one arterial bed. So even if your calcium score was 0, 60% of those people still had atherosclerosis. Even more interestingly, they found that 45% of people with a quote-unquote normal LDL, which was 110 at the time, had atherosclerosis. When LDL was at the upper limit of normal at 130, 58% had atherosclerosis, and when it was 150, 64%, almost 70% of participants had atherosclerosis. This is an otherwise young and healthy cohort of 5,100 people, about a 60-40 split men and women. The current recommended upper limit of normal is no longer 130. Obviously, it is 100 or less. Further, the Framingham 10-year risk score of most of these participants was 6%. So these were people that were considered generally low risk. We don't usually treat unless they're over 7.5%. So if you use the risk calculators, the 10-year risk calculators, these are people under 6% risk, which you would kind of just monitor, which is absurd. I don't do that. I don't let people run around with high LDLs just because the risk calculator says so. You know, I'm a cardiologist. My job is to make sure people never get heart disease. So going on. And so most of the participants had a 6% or lower score, and most participants, 85%, were considered low risk based on traditional risk calculators. That's a lot to think about. Based on the 10-year risk score, they would not have been placed on lipid-lowering therapy despite having extensive disease. So these people had very serious disease, almost 70% at one point had disease, and based on traditional risk factors or risk calculators, they would not have been put on medications. I would recommend pulling up the study. Well, you know, I'll put the links in below. In the PESA trial, you'll notice that a normal LDL of 110, 45% of participants had atherosclerosis, and it goes up to 64% as you go higher and higher. This is in a population that is otherwise thought to be low risk and healthy, with no obesity, no calcium, no traditional risk factors, no smoking. Even the risk calculators calculate their 10-year risk score as 6%, which is below the 7.5% or the 10% that would be needed to start treatment. Also note that people with an LDL cholesterol below 60 in this trial had no atherosclerosis. So this is another very important point. We know from the Jupiter trial as well, people below 57, and now from the PESA trial, the Jupiter trial is a lot older, people below 57 don't get atherosclerosis. There's no more progression of disease. People in the PESA trial, if they were below 60, also had no atherosclerosis. So this is kind of why we use 60 now as a cutoff. People above 60 are generally laying down plaque. People below 60 are not laying down plaque, and you could argue probably can't, depending on how low and, you know, obviously other things. The take-home message that even in young, healthy individuals, LDL cholesterol is what matters. Regardless of how healthy you are, you have plaque in at least one arterial bed, and up to 63% of people had plaque in more than one arterial bed. In November of 2023, a lot of you guys are like, oh my God, you never use current studies. You're from the 70s. Every single study in my book, almost, those 800 studies were all within the last few years. I think I quoted one study from the 90s because it was important to point out that we reversed what we used to think in the 70s, in the early 70s, by a study that was 20 years later. And then that study was updated again in 2007, then 2017. So most of these studies from this book were published in the last few years. Some of them were published in the future. I have access to studies that were not yet published in the journal yet, but they were already accepted and are going to be published. The book was published in November of 2024. I have studies from 2025 in the book because these studies are finalized and they're about to be published. They're just not published yet. And I have access to them because I subscribe to many of the cardiology journals, and, you know, the authors would send them to me. It would say proof on it. So, you know, it's not published yet, but it is a future publication. In November of 2023, an update was published to the PESA trial and showed that in only 6 years, 3D-IVUS was able to show significant plaque progression in these young people who are otherwise healthy but just had high LDL cholesterol. They found that if you treat the high LDL cholesterol and blood pressure sooner and earlier, you can see some plaque regression in just 6 years. And I'll put those pictures up here. It's a very cool graphic. Obviously, I wasn't allowed to use in the book, but it is in the blog. In this trial, the risk factor showing the strongest association with progression of plaque was higher baseline LDL cholesterol, obviously. The impact of higher LDL cholesterol and higher systolic blood pressure on subclinical atherosclerosis progression was more marked in younger participants. The younger you were, the more that the higher LDL and higher blood pressure actually affected you and made your disease worse faster. Regression of plaque occurred in 8% of individuals with prevalent disease at enrollment. The chances of 6-year regression of subclinical atherosclerosis was inversely related to baseline active smoking, male sex, higher fibrinogen, higher LDL cholesterol, and older age. Similarly, the Cardiologist trial, and this is another trial, 5,115 young men age 18 to 30 who were also healthy and followed them for 35 years. They examined many factors, one of which was LDL cholesterol over time. LDL cholesterol exposure before the age of 40 was associated with an increased atherosclerosis after the age of 40. They found a 20% reduction in CVD risk for every 1 milligram per deciliter reduction in LDL cholesterol of cumulative exposure. So cumulative exposure meaning like over years. So if we reduce your LDL from, let's say, 101 to 100, you have a 20% reduction over, that 10-year period or, however long they're following you. As an example, here we go. If person A has an LDL cholesterol of 100, see, I remember I must have written this. If a person A has LDL cholesterol of 100 for 10 years, that's 1,000 milligram deciliter years of exposure. If person B has an LDL cholesterol of 101 milligrams per deciliter for 10 years, they have 1,010 milligram per deciliter years of exposure. That extra 1 milligram per deciliter over 10 years increased their relative risk of atherosclerosis by 20% after the age of 40. They also found that the higher the exposure at a younger age accounted for worse atherosclerosis after the age of 40. The recommendation would be to treat it sooner and lower in your 20s and 30s to avoid serious atherosclerosis in your 40s and beyond. The authors concluded, and this is a quotation directly from the authors, these findings indicate that both cumulative exposure and exposure that happens earlier in young adulthood and more important contributors to midlife atherosclerotic events than later concentrations, with potential implications for early life primordial prevention strategies. So we want to prevent atherosclerosis from ever happening if possible, and the sooner, the stronger, and the faster and the harder you treat it in young age, the less likely you are to have it when you are older. They also found that those with the lowest LDL cholesterol, below 90 in this case, had a negative time to first visit, meaning they had a delay in the time before they had to first see a doctor for some of this stuff. This means that low LDL cholesterol conferred protection and delayed the expected onset of disease compared to their cohorts or the people in the study with them with higher LDL cholesterols. They also found that those with higher LDL cholesterol between 110 and 130 had ever increasing earlier and worse atherosclerotic events compared to the rest. And of course, I'm going to put the links are all on the blog. You can click and read them. In the area under the curve study, which I've mentioned probably earlier in some other videos and mentioned earlier in the book, they stressed that the longer you are exposed to high LDL cholesterol for a longer period of time, especially in your earlier years, the worse the incident atherosclerosis when you are older. The authors conclude, and this is a direct quotation from the authors, incident CVD event risk depends on cumulative prior exposure to LDL cholesterol measured by the area under the LDL cholesterol versus age curve, and independently on the time course of area accumulation. The same area accumulated at a younger age compared with an older age resulted in greater risk increase, emphasizing the importance of optimal LDL control starting early in life. That's a direct quote from the authors. The higher your cumulative exposure to LDL cholesterol from the ages of 18 to 14, the higher the chance of having incident atherosclerotic events by age 40. Obviously, the group represented by the highest cumulative exposure to high LDL cholesterol had the highest rate of incident CVD. Those with the highest LDL cholesterol had a 3 times higher risk of CVD than those with the lowest LDL cholesterol. So it's a 3x difference between the highest and lowest groups. If you need even more evidence, the population in the Lyon Diet Heart Study had an average BMI of 26 and an average A1C of 4.6. And less than 18% of them smoked. You know what they did have? Their LDL cholesterol average was over 160. This was a secondary prevention trial. Secondary meaning they already had a heart attack. Obviously, if your LDL is 160 or higher, you're probably going to have a heart attack. This was a study to see if diet could reduce risk of future heart attacks and events. That's what it means when they say secondary. You already had your first cardiac event. This is to see if we can prevent future events. Back to the text from the book. This was a secondary prevention trial. These young, lean, insulin-sensitive individuals all had a heart attack. I discussed this study at length elsewhere in the book. The only thing they had was their LDL cholesterol was extremely elevated. A study from January 2024 looked at people in the UK Biobank with a genetic mutation called ANGPTL3 that keeps their triglycerides very, very low. They had atherosclerosis proportional to their ApoB. ASCVD was not lower. So people with people with super low triglycerides because of genetic mutations did not have less ASCVD. They had ASCVD in proportion to how high their LDL was. The higher the LDL, the more ASCVD. And it correlated with what we've seen in other studies. For every 38 milligram per deciliter lower of LDL, you had a 25% reduction in atherosclerotic events. Medications that target only triglycerides without a reduction in ApoB have failed to reduce atherosclerotic risk. Hence, then there are no guidelines recommend this treatment. Another case report of a 51-year-old male who was quote-unquote a lean mass hyperresponder showed rapid progression of his coronary artery disease after stopping statin therapy and adopting a ketogenic diet. He was quite lean with a BMI of 23. He had a history of a prior stent in his left anterior descending, which is the widowmaker, 2 years prior. He had stopped his atorvastatin due to myalgias, muscle aches, and adopted a ketogenic diet. His LDL was 301, HDL was 73, and triglycerides were 71. Off statins. 2 years after stopping the statin, he had a massive heart attack, an ST elevation MI, which is the kind where it's an emergency and you have to be taken to the cath lab right away. He had a 99% blocked right coronary artery. He was treated with 2 stents. He was placed on Repatha and sent home with an LDL cholesterol of 14. And then I have the pictures and studies, obviously, on the blog. They weren't allowed to be in the book. A recent state-of-the-art review from March of 2024 evaluated the ketogenic diet and concluded that, quote, this is from the authors and from the study itself, it does not meet the criteria for a healthy diet after extensive research. For all of those claiming they are metabolically healthy and that high LDL cholesterol does not matter if your HDL is high or your triglycerides are low, please show them this data. Without a shadow of a doubt, LDL cholesterol causes atherosclerosis and you are at risk based on your cumulative exposure to high levels of LDL cholesterol over the years, especially if it began when you were a teenager. And this is shown in multiple studies. I've shown this chart a million times. Mendelian randomization. Some people are born with super low LDLs. Some people are born with really high LDLs. The ones with the super high LDLs have atherosclerosis at a younger age and faster and sooner. The ones with the really low have no atherosclerosis at all in some cases and everywhere in between. Another claim they make is that you cannot get heart disease without insulin resistance. They even go as far as to say that it's not the cholesterol that causes heart disease, that is the insulin resistance that causes heart disease. If that's the case, why is it that only 25% of heart attack patients have insulin resistance? How about the other 75%? They don't have insulin resistance, but still had acute coronary syndrome. How do you explain that? And of course, the study is linked in the text. Now, the other thing is that, like I mentioned in this study just prior to this, the Lyon Diet Heart Study, their A1Cs on average were 4.6%. These are people who had heart attacks. Their LDL was 160 or higher, and they had a heart attack with an A1C of 4.6%, which no one on earth would ever think that that is diabetes or anywhere near insulin resistance. Another study published in March of 2024 wanted to evaluate the impact of optimal cholesterol levels on subclinical atherosclerosis in young adults that do not have traditional cardiovascular risk factors. They looked at a subgroup from the Cardia trial, age 32 to 46 years of age, that did not have diabetes, hypertension, smoking, and dyslipidemia. Within that population, they compared 2 groups. One had optimal lipids and the other had suboptimal lipids. So here they did a subgroup analysis of people 32 to 46 that had no risk factors from the actual Cardia study. The group with the higher LDL cholesterol, total cholesterol, and non-HDL cholesterol had a 30 to 36% higher risk of calcium, coronary artery calcium presence, incidence, and progression. They also had a 42 to 40% higher CIMT thickness. This is carotid medial intimal thickness, which is like plaque in your carotid arteries. They repeated the analysis in those with the calcium score of 0, and it did not alter the results. So regardless of whether they had calcium or not, it did not alter the end results. So whether you have calcium or not, if your LDL is high, you're going to have problems, which I kind of mentioned earlier in the other study. Those with the highest LDL cholesterol had more atherosclerotic events, regardless of calcium score. So whether you had a calcium score or not, if your LDL was high, you had the most amount of atherosclerotic events. They also found that for every 1 standard deviation of total cholesterol, LDL cholesterol, and non-HDL cholesterol, you had a 30 to 36% increase in presence, incidence, and progression of calcium, and a 42 to 44% greater odds of composite mean CIMT, carotid media intimal thickening. In those with normal starting lipid panel, LDL cholesterol below 100, so these are, let's say, normal people, at baseline, for every 1 standard deviation increase in LDL cholesterol, you had a 108 to 270% increase in calcium incidence. These patients were followed for 20 years. It is a very in-depth study, and it's linked there. You can go read it. In April of 2024, the Journal of the American College of Cardiology published a research article looking at high-fat, low-carbohydrate diets in the UK Biobank cohort. They were evaluating ApoB and LDL cholesterol in matched cohorts. After 11.8 years of follow-up, 9.8% of those with a low-fat, high-carb diet had a major cardiovascular event. So, about almost 10% had an event, while only 4.3% of those on a standard diet had a major cardiovascular event. So if you were on a normal diet, only about 4% of people had an event. If you were on one of these high-fat, low-carb diets, about 10% of people had an event. That's like a 60% reduction if you ate just a normal diet. After adjusting for other CV factors, the risk remained significant and showed a 2.18x risk. So 2.2 almost times risk for those on the low carb, high fat diet. They also noted that 11.1% of those on the low carb, high fat and only 6.2% of those on a standard diet had severe hyperlipidemia with LDL over 193 milligrams per deciliter or 5 millimoles. It's UK, so they use millimoles per liter. So 5 millimoles per liter is 190 in American. So again, big difference there from 6.2 up to 11.1. In September of 2024, another analysis of the Cardia trial, so another analysis of one of the other trials, looking at otherwise healthy individuals 18 to 36 years old, found that LDL over 118, just 118, and non-HDL over 135, less than 135, ApoB basically, were the best predictors of likelihood to develop atherosclerosis. They also stated that the earlier that the lipids were addressed, the less likely they were to develop atherosclerosis. Dr. Michael Mindrum recently critiqued an accepted paper on the LMHR and was very critical of their manuscript because the authors did not understand lipid metabolism very well, and they downplayed the causal role of LDL cholesterol and ApoB containing lipoproteins in atherosclerosis. That is a direct quote from the article, and it's linked up, obviously, in that publication. Multiple other critiques of their methodology, lack of statistical acumen, and data analysis have been published. In this critique, and there's a link, Dr. Javier Gonzalez discusses, quote, invalidating errors that were made in their meta-analysis on low-carb diets, BMI, and LDL cholesterol, response to diets based on body mass, subgroup analysis. If you enjoyed diving deep into the statistics, you can read the full manuscript. He posted it on X, and there's a link to it. You can go read it. He mentions that they have other papers that make no sense statistically with p-values like 0.000000001 and things like that, which means that you're probably just making up data or you just don't understand it and have no idea what you're saying. So what about the LMHR and the new calcium and CT angiogram study? So now they're getting excited and they're trying to publish these studies with CT, calcium angiography and calcium scores and CCTAs and all that. And I have 2 other videos, one on calcium scoring and why it's pretty much useless. You're detecting end-stage disease, and why would you want to wait till you have end-stage disease to treat? All the studies I just mentioned showed that if you treat the disease when you're in your teens and 20s and 30s, you'll never have disease when you're older. Coronary CCTA, same thing. It's a luminogram. You're injecting dye into the lumen where atherosclerosis starts in the arterial walls. The lumen stays pretty wide open, even at advanced stages. Look at this artery model right here. The lumen of the artery stays pretty open even with advanced disease. So shooting a CTA of that, or even a cardiac catheterization angiogram that I do in the cath lab, not going to show the subclinical atherosclerosis or the pretty severe atherosclerosis that is in the intima and muscularis layers. So continuing on the text of the book. This is a really long chapter, like I said, but I said it's free. If you don't want to buy the book, go read it on the blog. What about the new study looking at calcium scores and coronary CT angiograms of lean mass hyperresponders? Doesn't that look promising? Unfortunately, there are a few major design flaws and problems with this study. The study was not designed to show any results. They excluded all patients with coronary artery disease. This makes it nearly impossible to show that atherosclerosis will develop on a short time horizon. You'll have to follow these patients for decades to see if any appreciable and statistically significant atherosclerosis ever develops. So the study was designed almost in a way that would pretty much show that nothing happened. If you would have taken people with an already established calcium score, already established atherosclerosis, and put them on this crazy diet, then you'd probably see some differences. But unfortunately, they selected people who are super healthy. It's like picking a bunch of diabetics and watching them for a year and a half. It's like choosing a bunch of non-diabetics and saying, we're going to do a study on diabetes, and you select out all the non-diabetics and try to do your study on diabetes by feeding these people sugar or something like that. It's just not going to happen. Nothing will happen. Here's the rest of the text. Imagine designing a study to... This is funny. I read my own mind. I wrote this book over a span of like 2.5 years. So it's funny that I still have like similar thoughts. Imagine designing a study to see if diabetes will progress, but you excluded all diabetics. Or imagine you designed a study to see if dementia would worsen, but you exclude all people with dementia. This is obviously very problematic, especially considering the short length of the study. The other problem with the study is that they used calcium scoring and CT angiography. Neither of those will show early stage subclinical atherosclerosis. You cannot see soft plaque. You cannot see soft plaque that is not encroaching on the lumen of the artery with either of these modalities. Both modalities can detect advanced atherosclerosis or very late stage or end stage atherosclerosis. Again, you are using testing that would show pretty advanced disease once it's starting to plug up the arteries or once it's starting to calcify, which is even longer and even worse. The way the study is currently designed, you would have to follow these people for 30 to 50 years to see any progress and then compare them to a group that has normal LDL cholesterol. This is neither feasible nor cheap, probably not even ethical. It will also be difficult to make sure they adhere to this diet. These diets are not easy to stick to. And once they have a heart attack or stroke, they're probably going to be put on medications and their diet's probably going to be changed. A better design would have been to take people with an already positive calcium score and just check it after a few years to see if it increases. This is a very inexpensive and easy way to show progression. It is also safer for the participants. You would have to expose them to this for a much shorter period of time. If you took somebody with a calcium score of, let's say, 30, and you put them on this wild diet and their LDL goes up to 380 and 280 and whatever, really high numbers like they have, over a year or two, maybe 5 for sure, you would see that 30 maybe go up to 60 or 50 or at least something. You don't have to wait till it's like 300 or 400, obviously. And it'd be safer for the participants because then you could scale it back and say, hey, listen, this is not good for you. Instead, they're doing the unethical thing where they design a study to show absolutely nothing. And then they tell everyone, hey, look, if you're metabolically healthy, it doesn't even matter what your cholesterol is, which is obviously untrue and has been proven over time by billions of studies. As discussed earlier, these studies have already been done and we know the results. Young people with elevated LDL cholesterol, regardless of BMI, insulin resistance, and calcium scores, or other factors, will develop atherosclerosis at an accelerated rate. Now, the next chapter in the book is, do you really need inflammation? That'll probably be my next video on here, that you don't actually need inflammation to have atherosclerosis. Every study that's been done that reduces inflammation, but you still have high cholesterol, you still get atherosclerosis. So that'll be the next section. So next chapter right after that is called Young and Full of Disease. In July of 2024, an article was published in the Journal of the American College of Cardiology that wanted to answer this exact question. This is called Young and Full of Disease. And I'm not repeating these studies. This is another study. I know they all sound kind of similar and they're getting redundant. Like I said, there's a billion of these studies. Can young people without any of the traditional risk factors still get heart disease, and what causes it? They looked at adults aged 40 to 65 that had a 10-year risk score of less than 5%. So it's very hard to find people with such a low risk score. The 10-year risk calculator below 5%, that is pretty low. It's pretty hard to find people with a super low risk score, meaning their risk for atherosclerosis is very low when looking at the traditional risk factors, which is age, weight, BMI, diabetes, smoking, kidney function, metabolic parameters, and other metrics. By all objective measurements, these were people with a very low risk of heart disease. They even looked at the presence of calcium or soft plaque in the heart. They found that most had plaque, and it was worse and more prevalent the higher the LDL cholesterol or ApoB. The graphics from this paper are quite impressive, and I highly recommend you take a look at them. And obviously, I have them in the blog version of this, not in the book, because those are copyrighted pictures and we couldn't use them. They also found that for every 10 milligrams per deciliter increase in LDL cholesterol or ApoB, you had a 13 and 20% increase in atherosclerosis, respectively. So if your LDL was higher by 10 or your ApoB was higher by 10, if your LDL was higher by 10, you had a 13% increase in atherosclerosis. If your ApoB was higher by 10, you had a 20% increase in atherosclerosis. This is not unknown. ApoB is a slightly more accurate marker, and the better measures the cause. LDL cholesterol is just in the ApoB particles, so that makes a lot of sense. As an example, nearly 70% of men with an ApoB over 120 milligrams per deciliter had atherosclerosis. So that's 70%. If your ApoB is above 120, which most people would probably be like, which means your LDL is probably around 100, 110. The number was 60% for LDL cholesterol over 160. So for those with an LDL of over 160, 60% of them had atherosclerosis already. The authors concluded, and I'm reading exactly from the conclusion of the paper, I'm not altering this at all. Among healthy asymptomatic middle-aged adults without traditional atherosclerotic risk factors in the U.S., coronary atherosclerosis on CCTA is common even at lower serum levels of LDL cholesterol, non-HDL cholesterol, and ApoB. Coronary atherosclerosis is more prevalent at higher levels of serum lipoproteins for both men and women, and high-risk plaque features are present but relatively infrequent in low-risk adults. These findings emphasize the importance of lipid-lowering strategies to prevent the development and progression of atherosclerosis in adults regardless of risk factors. So whether you had a lot of risk factors or not a lot of risk factors or no risk factors, if your LDL or ApoB was above a certain threshold, 60 to 70% of people already had subclinical atherosclerosis as measured by, very fancy imaging techniques. So how do we resolve all of this? And why is it important? I would never make a video about this because it's a bunch of nonsense. These people want to make it sound like, hey, I'm metabolically healthy. Nothing's going to happen to me. No, that's not true. It's a bunch of nonsense. But unfortunately, it's misleading the public. And it is my job as a cardiologist and as a physician first and as a human being. It is my job ethically and part of the Hippocratic Oath, first do no harm. It is my job as a human being, because I have a platform and I have followers, I get 5-6 million views a month across all platforms. It's my job, I believe, to inform the public that this is dangerous. This is not a thing. There's no such thing as lean mass hyperresponders and being metabolically healthy and not getting heart disease. This is literally the definition of insanity. If you have high LDL cholesterol, even without risk factors, even at low BMIs, at super low BMIs, even at diabetes, no insulin resistance with A1C of 4.6 and age 18 to 36 and super lean individuals and healthy and no triglycerides even. If you have all of that, you will get atherosclerosis if your LDL cholesterol is above 60. And the higher it goes above 60, the higher and more atherosclerosis you have. People, it's not rocket science. I've literally went through about, 20 studies maybe, and there's tons more, like I said. And if you go to all of those studies and click on the references section, there's probably 30 to 40 more studies in those studies, in each one of these studies. But this is dangerous. And these people always say, well, no. We're not saying LDL doesn't cause heart disease. We're saying it does cause heart disease. We're just saying, if you're metabolically healthy, maybe, we're just curious. We're just thinking about it. Like, that's nonsense. You're basically telling people, or the way people are interpreting it is they're interpreting it as, if I'm metabolically healthy, then my LDL doesn't matter, which is idiotic. You have a study of like 70 people, which is not even enough people to be considered a pilot study. Normally, when you're going to do a study, you gather up like 300 or 1,000 people, and you do a pilot study first. 70 is not a pilot study. It's like a bunch of dudes having some fun in a basement, trying to figure out something. That's not a study. It's not science. You're misleading people. You're causing more harm. I can't tell you how many times in my comment section somebody says, what about these LMHRs? What if you're metabolically healthy? Oh, Mr. So-and-so, it's not even a doctor. I wish it would have said Dr. So-and-so. It's like a chemical engineer, like a software engineer or something, like some computer science major that's coming up with this stuff. Like, if you want to trust your heart and your brain, because obviously LDL causes dementia, if you want to trust your brain and your heart and your limbs, amputations and whatnot, to a software engineer, electrical engineer, whatever it is, have at it. The alternative is you come to a cardiology conference and watch all the cardiology lectures. You have collections of cardiologists all over the world that think this is just a bunch of nonsense. One of the people who wrote a forward for my book, the cholesterol book, was Professor Ray Kausick, and he is the president of the European Atherosclerotic Society. The European Atherosclerotic Society's annual convention in Europe is the largest cardiology conference in the world. Why don't you show up? Go to that conference and be like, hey, we discovered something that you all have never discovered. We have this new magical science that is amazing, and we figured out this stuff that you guys couldn't figure out. All right, try it. Go, show up, come to our conferences, present your evidence. Let me see it. My guess is this is going to be laughed at. This is not science. This is not how you do science. And then the other thing that is more indicative, these people are all on these pseudoscience podcasts. They get on these podcasts that are like Gary Brecka and these podcasts that are just jokes. The other thing that's very telling in how you know if somebody's honestly a scientist or just making up stuff is they're not interested in the science. They're more interested in links, reshares, and clicks. They'll post something on Twitter or X and they'll say, please reshare this, please like it, please comment, let's get to 1 million views, 1 million impressions. Okay, no scientist would talk like that. Or they post they'll post it and say, please comment, let's get this shared all over the world, let's get this everywhere. No scientist who does that. I mean, if you're a serious scientist and you want people to take you seriously, you probably should post your data, and if other scientists feel that it's valuable, they will engage with it. Engagement farming and clickbaiting and click farming to prop up your study means that it's fraud. Your study is useless. It's not considered anything helpful, and you are clickbaiting and click farming and engagement baiting people to try to prop it up so it can spread. That's not ethical, and that is a bunch of nonsense. That tells you how useless the data is and how useless these studies are. And are you going to hang your hat for? And let's say you're a normal person. Let's say you're not one of these people. Let's say you're a normal person. It's like 20 years old. You're eating a carnivore or low carb diet, whatever, and your cholesterol goes up, your LDL goes up to 300. Are you going to hang your hat on this study of 70 people where I just presented studies with thousands of people, and we have data, we have studies, when I've posted these before, we have studies with over 25 million data points and 25 million person years of follow-up. Are you going to hang your hat on a study of 70 people that were followed for a couple of years, 4 years, 5 years, and the study was designed from the beginning to not show anything, and it doesn't show anything, and it's 70 people that probably have some weird genetics that you don't? You're going to hang your hat on that and say, my heart's going to be fine because these 70 people that ran their own experiment in their basement came up with some nonsense that are probably all genetic mutants anyways, and they have this strange genetics, and this is what I'm going to hang my hat on. Okay, go for it. We'll see how well you do. That's just a terrible idea. On the other hand, we have studies with 25 million data points, 25 million person years of follow-up. And I just presented studies with the women's health study, for example. I forgot how many people were in it, but we're talking like hundreds of thousands of people followed for 30, 40, 50 years. Some of them even more, all metabolically healthy, and A1Cs of 4.6, BMIs of 23, no calcium, non-smokers, non-obese, non-diabetics, HDLs and triglycerides the way you want them, but their LDL is high. They all ended up with heart disease at a much earlier age than you would expect. So share this with somebody who's doing one of these diets that thinks that, being metabolically healthy is just going to, they're going to be fine. It's absolutely not fine, people. And my job as a physician and a clinician, because I see this every day when you're on my cardiac cath table and I'm trying to bring you back, or one of my partners or one of the other cardiologists in the world is trying to bring you back, it's not fun. We lose a lot of young people to a bunch of nonsense like this. We don't want to. So please share this with somebody who needs to hear it, and follow me on all the social media platforms. Like I said, if you go on the blog, there's all the cool graphics and links to all these studies. You can read them yourself. Plus, click through the references. You'll like it. And I hope you enjoy this. Check you out in the next video.